There's quite a few questions to pass out, so I'd like to go ahead and start with Dr. Thompson. Chris, there seems to be a lot of interest in the TOR procedure, and two specific questions. One is, if you're limited and have to do APC alone, possibly for insurance reasons or whatever, how often between the sessions of APC would you bring the patients back? And how do you assess when you're done? And what do you do in terms of medical modification or treatment during the time that you're performing the outlet reduction with APC alone?
Sure, all good questions. So we generally wait 3 months, and that is to allow adequate tissue healing and really to see where the outlet's going to settle out, because we used to try to bring them back at 2 months, but the problem is a lot of times they were still very ulcerated and indurated and we couldn't do anything. Right. So 3 months seems to be an adequate window. If they're not continuing to lose weight, if they're still losing weight at 3 months, we'll certainly delay that. But if they've lost all the weight they're going to by 6 weeks, and then they're kind of flat or slowly gaining again, we'll bring them back in 3 months, take another look, and then repeat the treatment, if it's indicated. Now, rarely you're supposed to see some ulcers or something. Of course, we're not going to do it in that setting. And sometimes the outlet's really small, honestly. And then you have to think, okay, what's going on? We always will do a very careful dietary history and talk to them about what's going on throughout the whole process as they go through the 6 weeks of liquids. After APC, they still do a full 6 weeks of liquid diet, then 2 weeks of softs, and kind of progress from there. So, make sure they're, properly transitioning and whatnot. If all that's the case, then we'll bring them back for a possible repeat APC. Additionally, you can consider using medications there as well, right? So it kind of depends on their symptoms. If they're still eating larger portions and they don't feel full quickly and whatnot, then, it's worth looking. But if, in some circumstances, we'll start layering on medications. But I like to usually do at least one more session and then consider using the meds.
Great, thank you. In terms of stricturing after APC for TOR, have you seen that? And is that something we have to manage with balloon dilation, or how do you deal with that if the outlet just becomes stenotic?
Yeah, it can be tough. I think that, balloon dilation, no hard numbers on this yet, but I kind of suspect that balloon dilation is working about half the time, and the other half the time we have to put an aluminum opposing metal stent or be a little more aggressive. So these are kind of tenacious strictures that will form in a minority of patients, probably around 4 or 5% right now. So certainly something to tell them about when you're consenting them. And a lot of times these people it's hard to bring them back. They're like vomiting. And when you say, well, I have to dilate that, they're, oh, no, I don't want that. And it's so hard to drag them back to endoscopy and let them know you can't, vomiting is not a solution to your problem. That's something that you have to be aware of as well. But it is something to be aware of.
Great. Thank you for that response. Allison, there was a letter several years ago from the FDA, a warning letter about balloons and some complications that occurred. Do you have specific medical regimens that you put your patients on when they're on the balloon? Do they all have to be on PPIs, or is that variable now? And do you have them avoid any medications?
Yeah, that's a great question. And that's probably one of the more common questions that I get in clinic from patients who are interested in undergoing balloon therapy. So generally what I do is I test everyone for H. pylori ahead of time. We don't have great data that H. pylori could ultimately lead to ulceration in patients who undergo balloon placement, but it's an easy intervention and strategy. And I think anecdotally, we've all seen it a handful of times. And so I commonly am testing and then treating if positive before balloon placement. And I actually confirm eradication before I move on as well. It's a little bit different from how I manage some of my other bariatric procedures that I do. But with the balloon in particular, I do worry about ulceration and bleeding at times. I also have everyone start high dose PPI several weeks beforehand. And then I have them continue it throughout the 6 month period that they have a balloon in place. And I think we have not, I knock on wood when I say this, personally seen any major bleeds with with the balloon, but we've certainly heard of them. The other thing that I'm very careful about is knowing sort of the clear contraindications to balloon placement. And so each time I go in, I do a very thorough diagnostic upper endoscopy. These are, and generally elective procedures. And so they can be delayed if they need to be delayed. But we want to make sure that we thoroughly are examining the gastric lumen and also for a large hiatal hernia, because obviously that would be a contraindication as well. And then we've all had patients where, they say that they've never had gastric surgery before, but you get in there and they actually have. And so you want to make sure there's no prior history of even a Nissen, because those were the patients who were at highest risk of morbidity with the original pivotal studies that led to FDA approval. The other thing I like to tell people about, even though it's very rare, but it has been reported, is the risk of pancreatitis. Again, very rare. And also the risk of infection of the balloon and hyperinflation. We just had a patient who had her balloon placed in Jordan, actually, where most of her family lives, but she flew to Michigan 10 days after the balloon was placed to visit her daughter. And her balloon was about 3 or 4 times the size it was when it was placed 10 days prior. It's pretty incredible video footage I should have shown today. But obviously that's a very rare risk. We don't really know if it's a contaminant at the time of placement or the balloon itself sort of gets super infected by some sort of fungus. But these are the risks that I always warn everyone of. I think in general, as I mentioned during my talk, balloon therapy is very safe, but I do keep people on high dose PPI throughout.
Great. Thank you very much. Shelby, a question about the endoscopic gastroplasty and how we're dealing with insurance approval for these procedures, and has there been progress, or are we still focusing primarily on a patient pay program? Can you give us some insight into that?
So we have probably had about 10% of our patients get insurance coverage for ESG. It's really on a patient-by-patient basis. I think that we're definitely, continuing to at a national level and interacting with insurance companies. And I think the several things that we're really going to need to get consistent insurance approval across the board over time is that we really need to get a code for ESG. Currently, we're using an upper endoscopy undiagnostic code of 43999 to bill these procedures. And that makes it challenging to get it covered consistently. The other thing is at this point, since we don't have a randomized controlled trial that has been published, the MERIT trial has been completed. It has been presented. It's not quite yet published, but I think that's also going to help as well, because that gives us level 1 evidence, which is really important in order to get insurance coverage as well. The one thing to note on the balloon side, at least, is that we have gotten a balloon code through the AMA CPT code panel, and that will be available in January of 2023. So we are making progress with the endoscopic therapies, but it is slow going progress.
Great, I appreciate that. And maybe we could get some insight from the other 2 panelists about how insurances are working in their general area. Chris, can you tell us, you've had pretty significant success in moving the needle in the Boston market. What has been behind that, and what do you suggest for other individuals that are trying to be progressive in providing these services to their patients?
I think the key was really treating our procedures just like the surgeons treat their procedures, right? So we have every patient see the dietitian and see a psychologist and go through the exact same checklist that the surgical patients go through. And then we provide letters of pre-approval that are identical to what the surgeons would provide. And then I also met with each of the major insurance providers in our area and sat down and had conversations with them. So it's been a long process, but now we have really quite good success for revisions and primary therapy. It's a lot of work. You can't, there's no shortcuts there. But I think if you stick with it, it will pay off.
Excellent. And Ali, what's happening in your in Michigan?
Yeah, great question, Steve. So we've had a lot more success with the revision procedures getting covered than we have with any of our primary procedures. I similarly have some meetings planned with some of the major insurers, but it seems like something must have happened during COVID. I think there was a change in leadership with one of the major insurers in Michigan. And since that time, about maybe 8 months or a year ago, we've had a little bit more difficulty with some of the procedures that were traditionally much easier to get approval for. But that is all for the revision procedures. In regard to the primary procedures, we've only had one patient be covered for an endoscopic sleeve, despite a relatively rigorous program. Most of Michigan insurance will not cover it at this time.
Understood. Shelby, you met in some detail about the medications that are used in this population. How do you assess these patients in terms of which medication is right for them? Do you put all your patients on medications after an endoscopic bariatric therapy? And how are they getting paid for?
So no, I don't put all patients on medications. It's depends on a number of different things. One is their rate of weight loss and what their ultimate weight loss goal and the amount of weight loss that they're actually achieving. So that's number one. Because if their rate of weight loss is high enough and they're achieving their weight loss with the endoscopic therapy, there's no need to put on an additional medication. When it comes to balloons, I will have a discussion when the balloon comes out about starting medications, and I use both on-label and off-label use medications. So first off, if a patient has a comorbidity that could be treated by medication that also treats that also gets weight loss, I will potentially start that medication. So for example, if a patient has diabetes, we would consider starting semaglutide if their insurance plan would cover that. It would be at the diabetes dose and not at the dose of Wegovy, which is the weight loss dose. It's not covered by many insurance plans, but semaglutide or Ozempic, which is the diabetes version of it, is covered by quite a few insurance plans. The other thing that we might that we also look at is if a patient has concomitant depression, Contrave might be a good medication for them because that's Wellbutrin plus naltrexone. We also look at phentermine. It's the cheapest medication. So if nothing else is covered, phentermine, as long as patients don't have a cardiac contraindication, don't have issues with sleep, that might be a medication that you can try. Now remember, off-label use is anything longer than 3 months for that medication. So I do document that in the chart and do discuss that with the patients. The other medication that I use frequently off-label is topiramate. If a patient has migraines, that's a great medication to start because it will help to suppress their migraines, and it does have an indication for that. But in off-label use for weight loss, it gets about 5% total body weight loss in about 50% of patients by itself, and will get to 10% total body weight loss in almost 25% of patients. It's also in a retrospective analysis of multi-center retrospective analysis for weight regain after gastric bypass that was published in 2017. Topiramate, compared to all of the other medications, not including semaglutide because it wasn't approved then, was the most successful in getting weight loss in patients who had regained weight after gastric bypass. So I do use it frequently in my gastric bypass patient population as well. But really the first step is to say, does this patient need weight loss medications? Number two, would the patient go on a weight loss medication? Because any weight loss they get with that medication is going to go away if they stop that medication. It's got to be considered a long-term medication. And then the next step really is, can I treat some other comorbidity as well as get weight loss with this medication?
Great. Thank you all for your answers. We're almost to the close of the session. I think I'm going to take the moderator's prerogative here and ask Chris, if you could give us just a little look into the future here of where do you think this space is going in the next couple of years? And are there directions that we didn't cover today in the small bowel or other areas where you think there's going to be a role for bariatric endoscopy?
Sure. I think the two kind of most interesting areas for me are combination therapies and then personalized medicine. So with combination therapies, it's very important to understand mechanisms. And I think as we're getting more information and more knowledge about mechanisms, we could combine things. So maybe it'd be a gastric procedure with some sort of small bowel procedure, maybe a combination of gastric procedures or small bowel procedures, something to really optimize outcomes while minimizing, again, and keeping an eye on complications, adverse events. But I think that combination therapy, and that's not just for procedures, it's also for medications, right? So maybe a procedure with a medicine, there'll be a sweet spot. But then taking that to the next level of personalized medicine and trying to understand the patients better. Maybe look most basic things, looking at gastric emptying. If they already have delayed gastric emptying, they probably won't respond to a balloon or suturing because those kind of work by inducing gastric emptying. So I think that that's kind of the most interesting stuff right now on the horizon. But I'm very excited for next week because I'm going to try to get rid of the alpha loops. So this is something that's been bothering me for a very long time, Shelby. I was so happy to see your video. And I just want to know if there's a pointer. So I struggled with this concept before, but so are you rotating counterclockwise at the bottom to go up, and you maintain counterclockwise?
Yeah, I'm rotating counterclockwise to get back up. And you'll see it when you get in there to when you rotate. Because if you try to go the other way, it just gets tangled up.
That's the only way I've tried, and it's been a disaster. So that's very helpful. I might
follow the, you have the suture that came out of the last, that came out of the last bite. Just focus on keeping that on your left, and that will get you in the right position.
Excellent.
Amazing.
Thank you.
Chris, I was just going to say that, I asked Shelby to give this talk on how I do it, as in how she does it, because we've discussed these alpha loops and drawn diagrams and stuff like that many times. So I'm glad that she did it, and it was a wonderful talk. And I think, everyone learns from all these. So I'm glad that we could put it together. Thank you all.
Love it.
All right. Well, look, it was a great session. Thank you all speakers for a wonderful morning and an afternoon in your part of the world. And I appreciate all the attention from the attendees. We now have about a 5-minute break for you to grab your lunch and come back to our luncheon lecture. We're going to have a really special treat because Paul Menard-Katcher is going to actually dumb down, if you will, EndoFlip and EsoFlip for the interventional endoscopists. And he'll be explaining how we use these techniques in our practice. So for everyone from APIE, I'd like to thank you again for attending. Please do check the chat. We do have Christy Click put in the links to the supporters of our program. They are going to be available to answer individual questions as well as show you the devices that you saw on the lectures today. And I hope to see all of you next year in person at a location to be determined. Right, Mihir? All right. Thank you and have a great day. See you back at 12:30.